Imagine this. A patient is in shock. Monitors flashing, fluids hanging. You're trying to decide, is this heart empty or full? And you're trying to decide, is it time for more fluids or pressors? That's where LVOT VTI comes in, the quick Doppler measurement that can completely change how we manage shock. To help us unpack today, I'm thrilled to welcome Wendy Finnie, a leading voice in point-of-care ultrasound and passionate educator. Wendy has a gift for turning complex echo concepts into practical bedside skills, and today we'll learn how to use LVOT VTI. Wendy, welcome to the Emergency Department podcast. It's fantastic to have you with us.
Thanks, Wendy, for joining us once again in this podcast on echocardiography and ultrasound.
You're welcome. Pleasure to be here. Thank you.
Excellent. So, Wendy, we are going to talk about LVOT VTI, which is quite useful in the emergency department or in the intensive care unit in the theater. From your 30, 40 years of experience as an echocardiographer and as an educator, it will be very interesting to know your perspective on this topic. Please tell us a little bit more about this. So let's start with the very first question. What is it? What is LVOT VTI, Wendy?
Okay, so the LVOT VTI is a way of assessing what the cardiac output is with the measurement of the LV outflow tract, and it's a way of assessing stroke volume in your patient. Really useful in the ICU situation, but also in ED and used in other areas as well.
Yeah, so we consider emergency department as a part of ICU because there are some critically ill patients, and
Yes.
we start from here. Thank you
Yes.
for the introduction. And why it matters in the emergency department, or as you say, ICU, or in the theater? What is your perspective on this matter?
It's a reasonably easy measurement to obtain. It's non-invasive. The images are reasonably easy to get. Now that we have very good ultrasound machines, it's very easy. The machines do most of the calculations for you.
Mhm.
You just basically have to put in the correct measurements, and particularly good for your undifferentiated shock patients to help sort out what's going on in those patients. The other thing is you can, it's a real-time thing, so you can re-measure quite easily as well with a dynamic situation with your patients.
Yeah, so I find it really this is useful that I can do some measurement, give some treatment, and do it again and see if there's
Yes.
any change, and that can affect my decision making.
Yes, yeah, no, as you say, fairly easy to do and repeatable.
Yes, thank you. So what is the physiological basis? When I started doing the LVOT VTI, the thing that make me a bit concerned is that there is a lot of maths in it, and there is a lot of physiological background on it. Tell us a little bit more about this physiological basis.
Well, as you've got here, of course, cardiac outputs, heart rates times stroke volume. So it's a way of assessing what the stroke volume is, and then you can easily measure what the patient's heart rate is with your pulse wave measurements, and put that into the equation, and you get your cardiac output. Your two measurements that you're doing, of course, are your LV outflow tract measurement, which gets squared and placed into the equation, and your LVOT velocity, which you use with pulsed wave Doppler and the 5-chamber view on your ultrasound.
Yes. So these days we just need to know this is the background calculation, but the ultrasound machine, they can do the calculation for us. So we don't have to do the calculation for ourselves, which makes the life very easy for us.
Yes, it does. Yes, it does.
Tell us a little bit about the various steps that you use for the measurement of LVOT VTI. The way I do it, at first I check the LVOT diameter, then the apical 5-chamber view, and then I use the pulse wave Doppler just below the aortic valve. And then I trace the VTI, the curve, and the machine can do the rest.
It's really important that you measure the LV outflow tract diameter. It's the same position where you put the pulse wave Doppler when you're doing your 5-chamber view as well. They should be in exactly the same position.
So this is the left ventricular outflow tract. So where do you recommend? Do you recommend very close to the aortic valve, or about
Yes.
3 or 5 millimeter away, or below the aortic valve, somewhere
Just
here?
below the aortic valve, you'd measure it with the aortic valve leaflets open. Yes.
And that is inner edge to inner edge at mid-6th valve, right?
Inner edge to outer edge for all cardiac measurements are leading edge to leading edge.
Leading edge to leading edge. Yeah. So this is the parasternal long axis view, and this is the left ventricular outflow tract.
Yes.
And the underlying assumption is that the left ventricular outflow tract is like a cylinder. So if we know the diameter, we can calculate the area here.
Yes.
And with the Doppler technology, we can measure exactly how far the blood is traveling to, which is the height of the cylinder. So it looks like this. Do you agree with me?
Yes.
Wendy?
Yep. Absolutely. It's really important that you're nice on plane there with your long axis view, which you are in this view.
And on the right-hand side, I have got some further images here. So that's the cylinder, and we have got the diameter, and this is the height. So this is the calculation. The area of this cylinder is pi r square. R is the radius, and radius is the diameter divided by 2. And the volume is the area multiplied with the height. Height is the VTI, which is the distance this blood is traveling to. Most people, it is thought that most people have got the LVOT diameter of 2 centimeter. What is your take on it?
Yeah, that works in a normal heart. You just need to be very careful with anyone who has left ventricular hypertrophy or anything like calcific aortic stenosis. It can be quite hard to do the measurement when you've got a lot of calcium in the aortic root as well. But in a nice normal looking heart like this,
Yes. The reason I use the term 2 is because it makes the life so easy.
Yes, it does.
In this formula, 2 divided by 2 is 1. 1 squared is 1. So essentially area is pi, which is 3.14. And all we need to know is that what is the VTI, what is the height of the cylinder. Then we can calculate the stroke volume and then cardiac output. There is a bit of foreshortening in this apical 4-chamber view, but the reason I am showing you this is how we measure the LVOT VTI. So at first we get the LVOT, the left ventricular apical 4-chamber view, and then tilt it a little bit to get the apical 5-chamber view. And then once we use the pulse wave Doppler, the signal is just about 3 to 5 millimeter below the aortic valve, and it gives these beautiful waveforms. Now, what is your practice? How do you measure the LVOT VTI in your experience?
So you've make certain that you've got your you set on the right velocities, which you are there, the scale's correct. And then you would freeze your pulsed wave, then you would trace around the whole image there. Trace around it, come back up to the baseline, and then would mark there, and you would move across to the next one and to measure your heart rate as well, to put into your equation.
So the machine will do all the calculations, and it is giving me 18.3 centimeter, which is pretty normal, 18 to 22 centimeter. That's the usual LVOT VTI.
Yes, that's correct.
Excellent. Thank you very much. So what are the practical applications you find from your training or from your experience?
Well, I guess it's your fluid responsiveness, as you're saying there, wanting to know what the LV ejection fraction is to give you an idea of how well the pump is, handy to use in someone with pulmonary embolus. And again, you can repeat it, so you can do the measurement, give some fluid, and repeat it again later. So, and all those things you have listed there, very useful for.
And from your work as an echocardiographer, probably you have seen more of these type of cases, the heart failure patients.
Absolutely.
And in the emergency department, we see more of these, that is the shock patients or pulmonary embolism patients. What is your experience with these different types of patient presentation and their LVOT VTI, especially in case of heart failure patients? Well,
as echocardiographers, we don't generally measure the VTI as a routine measurement, because we're always doing the ejection fraction, and we're more based on that. I think it's a more useful measurement for point of care ultrasound. Where you're not doing ejection fraction, perhaps like we're doing. Heart failure is what we would be using it mostly for. You're correct. For you, it's your undifferentiated shock, shortness of breath, your PEs, your rest patients, I guess.
Thank you. In the course that you are doing in the University of Otago, you are incorporating the echocardiography as a part of the point-of-care ultrasound, and that's very useful for our practical application in the clinical settings. What is your take on the relationship between the POCUS and the critically ill patients?
Oh, incredibly useful. For me, undifferentiated shortness of breath, your patient presents, is it heart failure, shock, undifferentiated, or exacerbation of COPD, ultrasound, echo in particular, but also incorporating now the things like lung as well into it, is just critical. It's a fabulous tool to be able to use at the bedside. And your machines that you're using now are so much better that your imaging is a lot better as well.
Yes, and I find that the software is getting better, the hardware is getting better. In old days, there was this notion that you do echo or you do the lung ultrasound or you do the aortic ultrasound or fast scan. But these days we are traveling more towards integrative protocols.
Yes.
We do a bit of everything to get a bigger picture.
Yes.
Rather than focusing only on the heart or only on the lungs.
It's also something I think us as sonographers and echocardiographers could use more too. We're tending, those of us who are involved in teaching, and I've learned this through the Otago University course, I look at lung now and I'm looking at aortas more now, and I think an integrated way is absolutely the way to go with ultrasound.
Thank you. So there are a lot of patients that I have seen where LVOT VTI had made a big difference, especially as you have mentioned that in case of the shocked patient, we see a lot of shocked patients. And once we do the treatment, like giving some fluid, if we repeat the LVOT VTI in the same position, then we can see if the patient actually is responding to the treatment, which is a big difference. If the person is not responding to the fluid, then there may be something else that we need to do. So that is where the role of LVOT VTI is. Similarly, in case of the septic patients with a low VTI, the fluid is not going to help much. In this case, we need to give some inotropes, like some noradrenaline. In case of the pulseless electrical activity, cardiac arrest, to differentiate between actual pulseless electrical activity and pseudo pulseless electrical activity, and or should we give the chest compression or not, that can be affected by the LVOT VTI as well. What is your thought about it, Wendy?
Yeah, I think you're integrating LVOT with your other things as well. So, if you talk about fluid, you'd use LVOT in conjunction with lung, either wet or dry lungs, and AVC, JVP as well. PEA arrest, I think, really useful. Ultrasound is being used, echo is being used a lot in the acute situation to call or not call a PEA arrest. So, yep, absolutely. Very, very useful.
Now, in case of the cardiac arrest, most of the time we do the subcostal view.
Yeah.
And in subcostal view, how do you measure the LVOT VTI? Is there any tips or tricks?
Yeah, very difficult to accurately do that. Sometimes you can just kind of get a slightly, depending on how the aorta angles, you can sometimes get it, but it's likely to be off angle when you're doing that. Yeah.
It's very challenging there.
It's very challenging.
Yep. So I'm going to share a couple of cases here. The first case was a 68-year-old lady who came with some chest pain, shortness of breath, palpitation. We did a CTPA and that showed that there is pulmonary embolism. And this is the apical 4-chamber view. And when it is tilted a little bit, there is apical 5-chamber view. The right ventricle is dilated and the right atrium is also dilated. The thing that I was looking for in this case is what is the LVOT VTI? And the VTI in this case was pretty low, 14 centimeter. 14 centimeter is really low. So in your practice, if you find a patient with pulmonary embolism, how the LVOT VTI can affect their further care? Do you have any thoughts about it?
Yeah, it could do. You also need to be careful, and it's always a difficult one with LVOT, is there other features going on as well? So it's needing to be very careful there, that just what you're dealing with. I don't know that we would use, to be honest, in our practice, LVOT. We would be looking as an echocardiographer more at right heart pressure. But I understand for you guys it could be very useful.
And this is the person who has got a big, almost like a saddle embolus, both sides.
Yeah.
This was another person with young patient coming with some chest pain. So we got the apical 5-chamber view, and we did the LVOT VTI, which is pretty normal. It's 19 centimeter. Troponin was normal and ECG was normal. I could not understand why there was chest pain, but essentially I diagnosed that there is a normal VTI, normal stroke volume, normal cardiac output. All the parameters are normal. So essentially we treated as a low risk chest pain and discharged from the ED. With regards to this particular case, what my focus was the angle, the Doppler angle. So in this case, the Doppler angle is almost parallel to the direction of the blood flow. And so it's not quite an apical 5-chamber view, it's a modified apical 5-chamber view. Because in apical 5-chamber view, you keep the interventricular septum almost vertical, but here I have to tilt it a little bit to get a better view. Do you have any tips or tricks to get the angle right?
It's probably more important to get the LV outflow tracked than the septum. So it's making certain that that's the part that's coming straight up and down with you. You're going to get the best, the highest velocity that you can get. So it's focusing more on having the aortic flow straight up and down than that septum. So there it looks totally bang on. I would probably have the cursor slightly closer to the aortic valve if you could, but that's a totally normal looking LVOT. Yeah, VTI.
Thank you. In some of the machines, actually, you can adjust the angle, especially in these days, the new machines. But this one is a little old machine, and it was difficult to adjust. But still, that is the idea that the direction of the LVOT and the Doppler, they should be almost parallel, maximum 20 degrees. It should be less than 20 degrees. Now, there are some challenges. We find that the LVOT VTI is very useful. It helps us a lot, but also it has got some challenges and pitfalls. So Wendy, tell us a little bit more about the challenges and pitfalls for our viewers that we need to be aware of and how to address them.
So I think it's making certain that just what we were talking about, that you've actually got a really nice 5-chamber view and that you're perpendicular to the flow. Making certain that you've got your scale correct before you're doing your measurement, making certain that you're on pulse wave Doppler, not continuous wave Doppler, because I have seen people do that as well. So of course, continuous wave Doppler is going to give you the maximum velocity. It will give you the velocity going across the aortic valve. Atrial fibrillation is always going to be difficult. If we do any measurements in atrial fibrillation, we would do at least 5 measurements and average them. And any valvular issue will, of course, alter things as well, like calcific aortic stenosis or anything like that.
And the other thing I found sometimes that if the patient morphology is different, like in case of the obese patients, if I don't get a very good view, especially the apical 5-chamber view, I struggle to put the Doppler signal just 3 millimeter lower to the aortic valve.
Yeah.
Sometimes I put the color Doppler at first, and color Doppler can show exactly where the LVOT is, and then I can use the pulse wave Doppler there.
You can use the apical 3-chamber view as well. I would do that rarely, but just sometimes if I'm really struggling, particularly in a difficult patient, it may be a better view, and sometimes you might get it. So it's again how long you've got in your emergency situation to spend to try and get the view and how useful it's going to be for you. I think it's weighing up that time.
And the other challenge that I find that some of the clinicians, they do the measurement just once and that's it. I find it a bit challenging because, as you have rightly said, that we need to do multiple measurements. For example, in AF, you need to do 5 measurements to get an average.
Multiple, ectopics, that can be a problem as well. You should always do more than one measurement. Absolutely. If you're going to do it, you might as well do it properly.
Yeah. Thank you. So in our clinical practice in patients with shock, for example, we use LVOT VTI, but the other measures as well, like mean arterial pressure, lactate, and IVC collapsibility. Do you sometimes integrate the LVOT VTI with the other parameters, or?
Yeah, well, yes, I would always,
Yes.
actually. I would always.
Yes. Thank you.
So I would, but then I'm an echocardiographer, so I'm always going to do all of the views where at all possible. And I think that if you're making clinical decisions on your measurements, it is really useful if, again, depending on the status of your patient, if you're able to do multiple views.
Yes, thank you, Wendy. So I think the gist of the matter is LVOT VTI is not in a single entity. We need to integrate it with the bigger picture, with other parameters, as well as the patient presentation, the history, the physical examination, the ECG, the blood tests, and then we take a decision. As a trainer, what is your take on this particular topic, especially LVOT VTI as a part of the POCUS training curriculum?
So when I start teaching point-of-care ultrasound, I actively discourage clinicians from doing measurements because I find that the measurements are done incorrectly so often. I've now found, as time's going on, that the clinicians are coming to me to be taught at a much higher level. And in fact, their skills are particularly good. And so I think that they can learn to do these measurements quite quickly. And as you've written here, it is learnable within hours, not weeks. I think the important part is if you can get the views correctly, which those of you who are doing enough can. I'm a big believer that you should do some form of formal imaging, but if you can do that, absolutely you should do the measurements, and they are quite quick to learn.
Thank you. That is my experience as well, that it can be learned quite quickly. But what is more important is to retain that information, to retain the skill. We need to practice. We need to keep practice. Otherwise, easily it can get rusty and we forget it.
Yeah. It's something to do routinely. And I think it's something that if you have time to practice on and do it when you're doing other patients, it's a very handy thing, so that when you need to do it in an emergency situation, you've got the skills to be able to do it quite quickly.
And in the emergency department, we see this type of patients quite a lot. Patients with shock, patients with chest pain, patients with heart failure. And so we can apply this LVOT VTI quite often.
Yes. Absolutely.
And you have been using this, you have been doing this echocardiography probably 30-40 years, Wendy? Yeah. So what do you see, what do you envision for the future direction, especially with this AI and shorter and more capable instruments?
Oh, I think we're going to be doing a heck of a lot more, aren't we? It's hard to know where AI is going to take us. The change that I have seen in ultrasound machines since I've been scanning, the things we used to think we would be able to see were just ridiculous. Now things are so easily visible. The machines do the calculations for us. We just have to put the correct figures in for them to give us. I think it's going to be amazing to see where it goes. I don't know where it's going to go.
Sky is the limit.
Yeah, maybe.
So what are your tips and tricks, if you can tell to our viewers and the trainees, especially in case of the LVOT VTI, Wendy?
Well, I think it's just, again, make certain that you're getting your views correct, your parasternal long axis and your apical 5-chamber view. Make certain that you've got your angle correct, that you're on pulsed wave Doppler, that you've got your scale correct when you're doing your measurement, that you do more than one measurement and average it. Be careful for other abnormalities which could change things, so be very careful on your patient selection. But yeah, I think it's a reasonably easy thing to learn to do if you keep at it.
Thank you, Wendy. And one thing I would like to, as you have mentioned, that sometimes it is good to get a comprehensive examination, like in the echo lab, if they can have a formal echocardiography in certain cases.
Yeah.
From the emergency medicine point of view, sometimes it can be a little tricky because we are doing the bedside ultrasound or bedside echocardiogram that can affect our decision making right then and there.
Absolutely.
And then, of course, if we can do the formal echocardiography later.
Yeah. Absolutely.
So there are a lot of research on this topic, and future research is coming as well. A lot of works going on. especially these days in the emergency department and in the ICU, a lot of research going on. So I'm pretty sure we'll get more up-to-date knowledge and information on this topic. Thank you, Wendy. It was a great pleasure talking to you, and we learned a lot, as usual, from you. Thank you for taking time.
You're welcome. It was enjoyable.
Do you want to learn more about LVOT VTI? Get in touch. See you later. Please subscribe to the channel and press on the bell notification. Any questions, write in comment section below.